Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for December 1st, 2022. Welcome, everybody, back. We've been off for a while. We had Thanksgiving. We had Kidney Week. I want to thank everybody who came up to me at Kidney Week and express some appreciation for this conference. We put a lot into it. It means a lot to us, but it means more when we get that kind of feedback. So thank you so much for all the people that came up. It really makes what we're doing worth it. We've got a great case today. It's good to be back in the saddle. We've got a lot of polls involved, so it should be fun. We have nothing to disclose. This is being recorded and will be uploaded to our YouTube channel shortly. And obviously, our privacy statement holds to ensure patient privacy is preserved. All identifying information is changed to disguise the identity of the patient and protect the patient's confidentiality. If you are not on our email list, put a note in the chat and we'll get you on the email list for updates for conferences. Please join our YouTube channel and invite anybody else in your section or your group or your fellowship, whatever, to join us. We love having a large audience here. We've got a fun case today. Dr. Corbett is going to start with the protocol. Dr. Corbett? Dr. Corbett?
All right, I'm halfway through it already. Sorry, Roger. Sorry, everyone, I apologize. So we'll start over again. The patient is a 52-year-old white male whom we were seeing for evaluation of nephrotic syndrome. He has a long-standing history of hypertension for which he's been on an ACE inhibitor, lisinopril. He's had microscopic hematuria and proteinuria for 12 years with protein creatinine ratios ranging from 0.5 to 0.75 gram per gram. But the serum creatinine had been normal at 1.0 milligram per deciliter. 3 years ago, after a long plane ride, he developed a lower extremity DVT and a PE. He was placed on anticoagulation. The serum creatinine at that time was 1.17 milligram per deciliter. His albumin was 3.1 and his urine protein creatinine ratio was 3.5 gram per gram. Hypercoagulable workup, which included factor V Leiden, anticardiolipin antibody, antithrombin 3 level, protein CNS activity was negative. 2 years ago, he was diagnosed with an invasive squamous cell carcinoma of the right lateral zygoma, which invaded the right parotid gland and local lymph nodes. He underwent extensive surgical resection with reconstruction and radiation therapy. Subsequently, a CT scan of the chest demonstrated metastases to the lung, and he was treated with a checkpoint inhibitor, cemiplimab, for 8 months. After 2 years, his cancer was felt to be in remission. Several months prior to being seen by nephrology, he developed lower extremity edema. At the time of the consultation, his creatinine was 1.18 milligram per deciliter. Serum albumin was 1.8 gram per deciliter. And the urine protein creatinine ratio was up to 11.3 gram per gram. His past medical history was additionally remarkable for hypertension, which we've already said, hyperlipidemia, obstructive sleep apnea, and gout. Social history, former smoker, drinks alcohol socially, used no illicit drugs, and there is no family history of renal disease. His medications included lisinopril, amlodipine, furosemide, fenofibrate, atorvastatin, apixaban, and allopurinol. He had no allergies. His physical exam, his blood pressure was 156/84, heart rate was 56, his BMI was 25. HENT exam was remarkable for the post-surgical changes of the right face and neck. His neck was otherwise unremarkable for thyromegaly or adenopathy. Lungs were clear. Cardiac exam was unremarkable, as was the abdominal exam. He had 2+ pretibial edema, bilaterally. A neurologic exam was unremarkable with the exception of a right facial droop, which was a result of his surgery. And the skin was otherwise unremarkable for any rashes. The laboratory data at the time of the biopsy demonstrated sodium of 140, potassium of 4, chloride 110, CO2 of 23, B1 of 25, creatinine of 1.1 with an estimated GFR of 79. His glucose was 86, total protein 4.6, albumin 1.8, calcium 8.4. Total billion LFTs were normal. His cholesterol was 171, triglycerides 89, LDL 92, and HDL 61. His white count was 4.9 with a normal differential. The hemoglobin was 10.5 and his platelet count was 270,000. Urinalysis had 4+ protein with moderate blood by dipstick. Urine protein creatinine ratio was 11.3 gram per gram. Serologic evaluation demonstrated a normal C3. The C4 was slightly below normal at 11. The ANA was negative. Rheumatoid factor was elevated at 124. PLA2R, antibody, cryoglobulins, urine serum immunofixation were all negative. Hep B surface antigen, Hep C antibody, and HIV were negative as well. Renal ultrasound demonstrated the right kidney to be 13.5 centimeters in length, the left 12.5. There were no masses. He had several simple cysts noted in both kidneys. There was no hydronephrosis. And he ultimately underwent a renal biopsy for evaluation of his nephrotic syndrome.
Steve, what did his urine sediment show?
He had like 10 to 15 red cells per high power field. He didn't have any white cells.
Okay. Any other questions for Dr. Corbett? Great. A little bit of a complicated history, but I think a lot of relevant issues here that might give us some clues, which I'm going to ask Dr. Whittier to walk us through how he looks at this case with all those various clues.
Yeah, thanks, Roger. You know, I think the big thing that stands out here is a guy who's got normal renal function with nephrotic syndrome, and he's got persistent microscopic hematuria, previous DVT and PE in this cancer, which apparently is in remission with use of multiple surgeries and also the checkpoint inhibitor. So, you know, if I'm relating, you know, cancer to his nephrotic syndrome presentation, we always think about membranous, and just because his PLA2R is negative doesn't really exclude that at all. We think about NEL1 malignancy related, you know, membranous lesions or other membranous lesions, which are PLA2R negative, which could be, you know, consistent with his malignancy history. So I would have that pretty high on my differential. In addition, he got the checkpoint inhibitor, and usually I think about those as causing more of a vasculitic type of picture, but I think that there are some reports of those causing minimal change and even focal sclerosis. I may be outside my realm there, and I'd have to look up specifically. I usually think about them as causing more of a, you know, a T-cell mediated process, and you get this post-immune vasculitis is the most common, but I think that there may be other lesions there too, which could be nephrotic syndrome. I'm not thinking about him really as a purely nephritic since he has so much proteinuria. And so I don't think that that's as likely. But again, I'd have to review what the checkpoint inhibitors cause. And I bet that there is focal sclerosis and minimal change and maybe even membranous described there too. So I think all three of them are really on the differential. Could it be something else? Could it be something like amyloid? You know, I don't really see anything in his history that points towards that. Could it be, you know, rarely nephrotic syndrome could be an MPGN pattern, and he does have hematuria. And so I think about MPGN when you have a sort of a crossover with nephrotic range proteinuria and also hematuria, but his complements are normal, doesn't exclude it, but, you know, but his rheumatoid factor is elevated, even though his cryo is negative, and sometimes you could have an immune complex mediated MPGN and the rheumatoid factor is actually your cryo. It's just maybe the cryo isn't done right. So I'd probably put that in my differential as well. And I think that's probably about it. I'll kind of call it quits there.
So I think you're right. I mean, the problem with this whole checkpoint thing is kind of like the problem with GN after COVID immunization. Everybody starts seeing everything and they report everything. And we don't really know exactly how much is related or just happens to be a coincidence or not. But, you know, I think you're going to find a report of, as not only with, you know, immune stimulation with COVID, just about every GN, including even anti-GBM disease, showing up to the same thing with checkpoint inhibitors.
And I should have said the obvious, most common lesion we would see with checkpoint inhibitors is interstitial nephritis. But what I was talking about is checkpoint inhibitor-induced GN.
Yeah, really good point.
On those. Yeah,
really good point. In the text boxes asked about cryo. The cryos were negative. Another person said kidney size can hint towards amyloidosis. Kidneys are 13.5 and 12.5. I think that's and the upper limit of normal, but I think that's also a good point.
Bill?
Yes.
Yes.
Bill, I have a question for you. You kind of skipped over the low C4 and the positive rheumatoid factor, hematuria and proteinuria. I don't pay much attention to a cryoglobulin negative test. They're commonly false negative anyway. But what concerns me is there was no hepatitis C viral measurement. I usually, even in an antibody negative patient with this pattern of complement and rheumatoid factor, would measure an HCV virion semi-quantitatively.
Yeah, I
Steve,
definitely
Steve,
brought
do
up.
we have that by chance? PCR or viral? Okay.
Yeah, it's a great point. Thanks for bringing that up. I think I was sort of relying there on that Hep C antibody being negative, but I think you could probably have an immune complex mediated. Yeah, and the same thing. I saw the cryo was negative, but the fact that the rheumatoid factor is high and the C4 is low, and there's hematuria with nephrotic syndrome does point towards maybe an immune complex mediated MPGN. And and if it is, obviously, if it is that, we would have to make sure that the Hep C RNA is negative, because that would probably be the most common cause.
Cryos are often negative, as Dr. Glassick pointed out. I don't know how much of that is because it's just a difficult test to do properly, or it can be because the test is done properly and it just isn't a good enough test. I don't know the answer to that. I know it's very operator dependent and institution dependent. I think we're pretty good as a general rule at picking that up, but by all means, that's a good point. When I see a rheumatoid factor in a GN case, I think of, they may just triggers a couple things. It triggers cryo and it triggers endocarditis or some chronic infection. Steve, was echo done?
He'd had an echo before. There was no evidence of any vegetations on his
No,
valves.
because we've been fooled even with negative, without any other evidence of GN, with some of these very low grade, as Bartonella or something, so, but that's what I kind of think of. As far as the complement being low, I mean, a low C4, sometimes it can, if it's really low, I think about a cryoglobulinemia. It's an in vitro phenomena, but not 11. It's usually 2 or 3. But it's hard to know what to make of. I kind of have to agree. If anything alarms me, it's the rheumatoid factor, but I don't know really how to put it together, unless we're hiding a Hep C somewhere, as hinted by Dr. Glassick. Anybody else have any thoughts? Otherwise, we'll go to our poll and see what everybody thinks. Yes, Dick.
The other point, Roger, is we've discussed this on many occasions before. This patient has pretty severe nephrotic syndrome with an albumin of 1.8, yet his LDL cholesterol is only 92. And he's on a statin and a phenofibrate and so forth. That may be the explanation, but that's a strikingly low LDL for a nephrotic patient. It suggests liver disease.
Good point.
And maybe amyloid, I don't know, maybe occult cirrhosis, who knows?
Super. Let's get to our first poll here.
Roger.
Yes, I'm sorry.
Welcome
Welcome
this
back,
is Maria, a voice from the past.
But welcomed.
Thank you. In addition to Bill's excellent differential, a secondary FSGS due to the sleep apnea needs to be considered. I am still fascinated by the globulin gap, which this patient has. So an MGAS is also a possibility, and I don't see a SPEP or immunofixation being reported, nor free light chain. So I'd like to know the results of those.
It's down there. Urine and serum immunofixation were negative.
Okay. So I need to have my eyes examined. Thank you. That's
Yeah.
all.
It's small print. Trust me, I have a hard time seeing it too.
Okay. Let's do our poll. See what people think. So, what do you think this patient has? Membranous glomerulonephropathy, focal sclerosis, an MPGN pattern of injury, idiopathic nodular glomerular sclerosis, or IgA nephropathy.
One more thing, Roger, what these people vote, well, the attendants vote, just to reinforce what you said, there are two classical reports regarding checkpoint inhibitors and GNs, one from Colombia, the other one from Kennard Javeri and MD Anderson, and basically anything is possible. All entities have been reported for the most part.
Great, thank you. Wait a couple more seconds.
All right, last few. There we go. All right, we'll end it there.
All right, so interesting. We've got 42% think it's membranous. One person says focal sclerosis. 52, about the highest 52% says an MPGN pattern of injury. And another person said idiopathic nodular glomerular sclerosis. Nobody bought IgA nephropathy. So does that influence you at all, Bill?
You know, I think membranous was up on my list as my top number one. So I think I'm pretty close there. And I think I mentioned that MPGN would be there too, just because of the combined nephrotic and nephritic. I always think about that. And then we talked about how the rheumatoid factor is elevated and so on. So yeah, I think an immune complex mediated MPGN may be there as well.
Terrific. Let's spin the wheel and see who reads the case.
A good point in the chat regarding the allopurinol in association with vasculitis. I think we do. Dr. Corbett, do we have ANCA?
No, there was no ANCA done on it.
Okay.
That's a really good point. We think about hydralazine a lot, but allopurinol is the other big one on that list these days. Okay. I had to oil the wheel. It's been so long since he's been spun.
You changed the weight, right? So
It's kind of like the Scarecrow in the Wizard of Oz, you know, it needs to be. So it's a Chintab. Chintab is in India, so I'm going to call on Melanie to read this. Melanie, you're Chintab's proxy today.
all right, Mel.
Melanie's our second-year fellow, GlomCon fellowship candidate or member. Had a busy day already, but I'm sure she's charged to do this.
All right, Mel, go ahead and mute. Okay, I'll just have you share the screen here. Give me a second. Give you control. Click on the screen.
Let me just turn.
Yep, and then you can advance. Yep, go ahead. You can go past this one. Yep.
Okay, so here we have 3 portions of a core biopsy with trichrome stain at low power. Maybe some areas of fibrosis up here, a little bit here.
Actually, that was a glomerulus you just went over. The cores are really thin. Above that, yeah, right there, that's a glomerulus.
Yes, I think I was just scanning and speaking too quickly, Dr. Simbler.
It's a 30-gauge needle.
Yeah, pediatric needle maybe. This area here also appears to have a lot of fibrosis. But this sample here looks like those appear back to back. Epithelial cells don't look like they're injured at all, but we'll see at like a higher power view.
Okay.
I only see like one glom here.
Yeah, and that little hole above it was a dislodged glomerulus.
This one,
yeah.
right? Oh, okay.
Okay. Yeah, so it's a small sample, focal fibrosis like you saw, and three gloms on the light microscopy.
Okay. So here we have a high power view of a glomerulus with H&E stain. You can see a lot of mesangial hypercellularity. Where's my pointer? In these areas here. Here, I'd say, is this like would you call this like endocapillary hypercellularity?
Yeah, hypercellularity. Yeah, there's no open loops in that segment.
And then there's like some mesangial expansion
Yeah.
as well here.
Does the glomerulus have a lobular appearance?
Yeah, you beat me to the punch. It does appear lobular.
Good.
Otherwise, looking at the surrounding tubules, at least this one up here looks okay. Doesn't appear injured, but not much other architecture, not a lot of interstitial hypercellularity, because I know he was on the checkpoint inhibitor. And so if we were
Yeah,
thinking-
no infiltrates in the interstitium here.
And Mel, I know it's an H&E. If you could go back, sorry for just a second. Right there at 6 o'clock, those two loops, do they look a little thickened or a little bumpy on the endothelial side?
What?
Right, it's around 6 o'clock. There's two loops that are sort of open, but see how, yeah, they look kind of thick on the
Here?
endothelial side. Yeah.
Yeah.
Is there anything there, David, or is it too much to call on an H&E?
Yeah, I think the capillary loops do look thickened over around 9 o'clock. Yeah, over there to the right a little bit. As I make my way around the glomerulus, that they do look thickened.
Click on the screen. Oh, there you go. Yep.
There we go. Okay, so here we have another high power view of the glomerulus with a PAS stain this time. Here you can really appreciate the mesangial expansion, still even being PAS. You can see areas of hypercellularity. Again, at the peripheral areas of the capillary, like the capillary loops look occluded or collapsed. I guess they're not open.
Well, I think they're kind of compressed from all that mesangial matrix expansion up there.
Yep.
Yeah.
At least the Bowman's capsule's intact.
And then look at like 4 o'clock. What do you think of the capillary wall thickness over around 4? Yeah.
They're quite thickened.
Yeah.
They're here. Interesting. What's this, Dr. Simblick? Is this like a nodule? Or is that just like a
No, I mean, it looks like a thick area. Yeah, I can't make out an open loop through there. It might be an early scar.
Okay. So here, a high power view on the Jones-Silver stain of a glomerulus. Here I'm just looking for spikes or holes. It's not, I don't see a lot of black uptake. But I guess, yeah, what I can comment on is like here, like when we were looking at the capillary loops, you know, they do appear thickened here, and perhaps this is like splitting of the basement
Yeah. Double contouring. Yep.
membrane.
Those look like, is that nuclei in there, David? Interposition? Is that over-
Yeah. It looks like there's 3 nuclei there on the periphery of that loop. Yes, yeah. Overall, it looks they have complexity to them. It looks like there's some remodeling over around 10 o'clock. Yeah.
10 o'clock.
Yeah, and down to the right a little bit. Yeah, move straight to the right.
Oh, this way?
Yeah, you moved up a little bit, but yeah, you could definitely appreciate some complexity, remodeling, layering of the capillary walls. If you move straight to the right, you would see some complexity to it. Okay.
No, sorry, that's just me clicking. Are you like this area here?
What see, that's mesangial, but
Here?
oh yeah, you just went over it back
Yep.
right there. Yeah, see, that's a lumen there. When you go down, there's a lumen. That white area is a lumen. So yeah, if you look around that periphery, it's all remodeled and thickened and,
Okay.
and multi-layered of that loop.
What does that tell you? That this has been going on for a long time?
Yeah, I mean, also, I mean, we have a membranoproliferative pattern of injury, right? Lobular appearance. And then we have double contouring and remodeling on the silver stain. So it supports MPGN.
Well, keep in mind, this guy's had a history of proteinuria for over 10 years. So who knows how long it's been going on.
Yeah, very true. But if I know membranous was on the differential, I'm not really seeing any spikes or holes here, or would you, or when the capillary walls are like this thick, does that kind of not come into play so much on the silver stain?
In old membranous, you could start to see mesangial interpositioning, but I would still expect to see some spikes and holes.
Okay,
Um,
thank you.
Yeah.
Okay, so here we have immunofluorescence staining for IgG that appears to be predominantly in the capillary walls. I wouldn't describe it as granular appearing.
Yeah, so in some areas it looks granular, and then in other areas kind of band-like where it's more confluent. Sometimes when it's full of deposit, it becomes not true linear, but kind of more band-like.
Okay.
Yeah, so up at 1 o'clock, you could see it's more granular in that area.
Like up
And then
here.
I think in the rest of the glomerulus, it's so full of deposits, it gives a kind of a appearance of being linear.
But the other thing too, David, right, is where are those deposits? We just know they're in the wall somewhere, right?
Right.
We don't know if it's subepithelial or subendothelial or even intramembranous from that standpoint. And so the whole issue of this membranous, I guess, is, as you were alluding to, Mel, it might still be in play. And I mean, I think the tram tracking is something that kind of leads you away from that, but the EMs I think will be helpful.
Right. And then I think the next one will be the light chain. Let's see. Okay, so here we have IgG immunofluorescence staining for both kappa and lambda, and they appear to be equal to me. I don't think that there's any light chain restriction. Okay, so here we get the numbers. So it was +2 for IgG, trace +1 for IgA, +1 for IgM, C1q was 2 to 3 plus, C3 was 2 plus, and kappa lambda was 3 plus.
So everything.
Yeah,
Full house.
full house, yeah.
Yeah.
I guess for the other learners in the audience, a full house means when you have like 3 IgGs and 2 complements, right?
Right.
Like in poker, like 3 and 2 of a kind. I thought that was fun fact. So here we have a high power view of the electron microscopy. I guess here, this is the capillary wall. This is the capillary lumen. Here we have the urinary space. So definitely it's thickened, and I can see a lot of electron dense deposits intramembranously here.
Yeah, so I would describe those as mostly subendothelial, because I could still make out the basement membrane above those deposits. Yeah,
Okay.
right there. Yeah, see, I could still make out a basement membrane. And then these are underneath that, a subendothelial side.
Okay.
And then this is why they appeared so thickened on H&E, and we have the splitting on the Jones stain, because then your new endothelium, your new layer is, if you could put the arrow there.
This one here.
No, keep going down.
That's there. Yeah,
Oh.
keep going. Yeah,
Right
right
there.
there. That's your new layer of inner basement membrane.
Oh, okay.
Plus you've got mesangium interposing there as well, along with those deposits.
Yeah.
And that's this is the mesangium that you're referring to?
Yeah.
Yeah, those are cell processes that should be in a mesangial area.
Okay, that's helpful. I just assumed because the deposits were in the middle that was like intramembranous. So if you can see this clear basement membrane, they still count as subendothelial.
Well, plus
Right.
you see no subepithelial deposits whatsoever,
Okay,
right?
great.
No, it's really the second basement membrane that helps you too.
That's true. Yeah, I missed that completely. So thanks, guys.
But even in membranous, if it was real, you'd see subepithelial deposit, but some might be intramembranous, et cetera, but you would definitely see subepithelial deposits, and there's nothing here.
Right. And then to comment on the podocytes, I don't see any slit like diaphragms. Would you call this like diffuse effacement?
Yeah.
Okay,
Yep. And then lastly, you have, right, the arrow right now. Yeah, there you go. You have a mesangial deposit. You were on it, skirted over it for a minute, but yeah, right there.
Here.
You have
Okay.
mesangial deposits as well.
Okay. Okay, so here, is this the glomerular basement membrane here?
Hmm.
Is this mesangial interpositioning then? here?
Yes. Yep.
And then this is the capillary lumen.
Yeah. So you can see how narrow that lumen is now, becoming very,
Reminds
narrow.
me of the one he
stenotic.
pointed out on the
Yeah.
light where there was a tiny little hole there with
Yeah.
a lot of complexity.
Yeah.
The wall.
And if you go around to the original basement membrane, you can see those subendothelial deposits again.
Right up in here.
Yeah, keep going all the way around though. That's kind of right there. All to the far, yeah, exactly. To the far right, that's where the original membrane is, and you see all those deposits under it.
Right. And again, you can, if we're looking at, this is the urinary space, this is the foot process again, appeared diffusely effaced.
Yes.
Okay. Wow. Next.
So before we go to that, Mel, what's your pathologic diagnosis?
Okay.
Roger, may I ask David a question before she tells us what she thinks?
I certainly hope so.
Were there any tubular reticular inclusions, David?
No, none were seen.
And were there any
Alright.
fibrils, David? Because cryo sometimes can have fibrillary structures.
No, the deposits appeared granular, as you saw here in the picture. There was no substructure to
question.
them.
Yeah.
So what is the diagnosis?
What's your histologic diagnosis?
Membranous proliferative glomerulonephritis.
That's not a
It's,
diagnosis.
I knew he was going to
but-
say that.
Dick, I didn't ask her for a clinical diagnosis. I only tell them they have to give us.
It's not a histopathological diagnosis.
All right,
either.
it's a pattern of injury.
Yeah.
Don't call it what it's not.
Well, she called it what the pattern of injury is, and that's what she was
That's
asking.
not a diagnosis. That's a histological descriptive term.
I understand, but we have to work on a
Roger,
diagnosis.
it's not a trivial point.
No, it's not, but
not
we
a
don't have a
trivial
diagnosis.
point.
We don't have a diagnosis yet.
So do you want to call this idiopathic disease?
Well, by exclusion, I think that's where we're at right now.
Well, Dr. Sethi and Provenza and I don't believe that that entity exists.
Okay.
That's because you guys can always find a cause, but we're not as good
That's
as you
right.
to always find the cause.
So-
We're going to move on, Dick. I'm sorry, Dick, but we're going to move on because there is more to
Okay.
this case.
Well, I think there's
Okay.
more to say here, right? I mean, this is, whatever you want to say, it's an MPGN pattern, but what else did you find in that pattern? Was it C3? No. It was immune complex mediated. So I think that becomes, an important distinction as well. I don't want to get it. I don't have a dog in this fight, so I'm not going to get in the middle of it because I know you want to move on. But it's an MPG, it's an immune complex mediated form with an MPGN pattern, if you will.
And that's what the clinicians had at this point. So, and they made a decision for treatment. I want to see what people would do with this. Now, if I understand you don't have a diagnosis as Dr. Glassick put out, but we do this, this is what doctors have to do sometimes. We have to treat based on what we see, where we may not know what's going on exactly. So what would you treat this patient with? Prednisone, cyclophosphamide and prednisone, MMF and prednisone, CNI plus or minus prednisone, or an anti-CD20 agent like rituximab?
Aspirin and dipyridamol.
Oh, Bill.
Oh,
Bill's
you're
still
right.
living in the 70s.
Exactly.
You're reaching back, way back.
I'm just explaining the history.
Bill, you were in grade school when people used aspirin and dipyridamol. You're not allowed to go back that far.
Northwest.
Wow,
Get a
well,
couple more seconds here.
some nice answers. Come on, a few more. There we go. All right.
So you can all see this, but it's really interesting. There's hardly a mandate. The biggest vote was on MMF and prednisone, then cyclophosphamide, and then after that, it looks like rituximab or an anti-CD20 agent. Bill, what would you do?
Well, I'd like to just take a second and talk about this MPG pattern of injury, and then that'll lead me into my decision to treat. And you know, the immunofluorescence is just so important in this pattern, and that in the patterns that we can have is everything is negative, and then we think about our vascular phenomenons, sickle cell disease, antiphospholipid antibodies, maybe chronic CNI use, et cetera. C3 alone or C3 dominant would be C3GN. Light chain restriction would, of course, be looking for a clone in the bone marrow. And then when you have this sort of full house pattern, we think about, you know, immune complex mediated. So I would definitely rule out hepatitis C with this pattern and make sure that lupus has been ruled out as well with this pattern. And if really none of those came back as positive, then I would probably I'd be in between giving cyclophosphamide and steroids or possibly Rituxan and steroids. And I'd probably just pick Rituxan. And I don't really have data to say that. that's what I would probably go with first.
Dr. Glassick, I know that
That's a very interesting choice, Bill. I would point out that a number of randomized controlled trials carried out in the 80s in patients fitting this description using cyclophosphamide were negative. And they were large and they were well powered. And there was a large international study of children with this disease in which steroids was used and there was no clear benefit. I think the evidence strongly points to a lack of efficacy of cyclophosphamide and steroids in this disease. And I would not, and I do not use that combination in a patient like this.
What would you treat him with?
Rituximab, by default. I don't
That's
have
interesting.
much better data, but I don't like cyclophosphamide.
Well, it's interesting because Bill's nickname, of course, is Rituxabil, and he for once didn't fall into the rituximab.
No, I did say Rituxan is what I would give, but I said
I'm sorry, Bill. I apologize.
I said I was kind of in between. You know, you may argue that MMF and prednisone may be the best just because that seems to be the best data with C3GN, but obviously that's a different disease. But really, it's, you know, trying to figure out the cause. Ed Lewis used to always tell me to treat it like lupus.
So what's interesting is that rituximab might work, or that would be the choice when cyclophosphamide doesn't work. And it just seems to me that in most things that I think about where I would use to make a decision between cyclophosphamide or anti-CD20 agent, for instance, membranous or vasculitis, they both seem to work. And if indeed rituximab would work in this and not cyclophosphamide, I would find that kind of a little odd in my mind, because I think of them as kind of similar mechanisms, but one's a little more tailored and perhaps a little safer. For sake of time, Steve, you want to take it from here?
Sure. So after much thought and after talking with his oncologist who felt he was in remission, I wanted to make sure that they had no problem with us starting any kind of immunosuppression, knowing, as Dr. Glassick alluded to, that there's no great data with what's out there. And actually the 2012 KDIGO guidelines, which I realized was some years before this, talked about prednisone low dose alternate day, actually, with either cyclophosphamide or MMF. And, whether it's warranted or not, this guy had such invasive and bad squamous cell carcinoma, I was kind of leery about anything. But after talking to the oncologist, he felt it'd be okay to go ahead and try something. So we started with prednisone and MMF. And as you can see, he was on that for some time without much benefit. I mean, he came down a little bit, but he continued to be nephrotic. And where you see the rituximab, I actually sent him to Fernando because I was a little perplexed on what to do with this gentleman. And for Fernando, who actually said it looks like MPGN, immune complex mediated, he agreed, because at the time that's what rituximab, at least for me, was becoming more of a therapeutic option. He agreed it would be worth a try. So we gave this gentleman a gram of rituximab 2 weeks apart with really little to no benefit. And we were, at the time, we were tapering off the prednisone and MMF as well. just to see over time whether or not the rituximab, knowing full well it could take 6 months or more to see an effect. And as you can see there, his proteinuria just continued to get worse.
So clearly, at least over 6 months, it didn't seem to do anything. So we have another poll now. So what would you do next? Would you give RAS inhibition, SGLT alone? In other words, you've kind of given up immunosuppressively, just treating hemodynamically. Would you use cyclophosphamide now, with or without RAS and SGLT? A CNI, with or without RAS and SGLT? MMF, with or without RAS, SGLT, or rebiopsy?
This is about 2 years after, right, Steve, after the initial biopsy?
Yes.
Okay.
What happened to his kidney function, Steve, over that period of time?
a really good
You know, his
question.
creatinine vacillated. You know, he was pretty nephrotic. So if you over-diuresed his creatinine bump up, but often, you know, it ranged between, 1 and 1.5. Sometimes he would get up to 2, but generally he would range between, 1 and 1.5 milligram per deciliter. Interestingly enough, it was fairly preserved.
Thank you.
Nice. Gonna give a few more seconds for more votes, but it's gonna be
Yeah,
interesting.
it's a pretty interesting poll here. You want to close it?
Yeah, here we go. You can.
So it's pretty equal. I mean, there's no mandate here. Everybody could probably make an argument for their, we've given it the college try. We'll just treat hemodynamically, or maybe try CNI to get the proteinuria down. MMF, and the highest is interesting rebiopsy. Steve, tell us what you did.
Well, that's actually kind of right where we ended up, is a rebiopsy. At that point, I again called my friend and colleague at the Mayo Clinic, Fernando, telling him, kind of going through what had happened, and wanted him to see the gentleman again, just to see if he had any new thoughts, especially since this was kind of an area of interest of theirs in general. So I sent him back to the Mayo Clinic, and they rebiopsied him there.
And Steve, his cancer still remained in remission this whole time.
Yeah, I mean, he has his squamous cell cancer has amazingly stayed in remission throughout this time. One of the issues early on, while they were treating him with the checkpoint inhibitor, was they didn't want us to rev up his immune system. Or I'm sorry, they didn't want us to inhibit his immune system because they were trying to rev it up. And that's why we waited for a little while before we actually started. But yes, his cancer, to the best of our ability to determine it, was still in remission.
So let's look at the path of biopsy number 2. And Mel, you're still on. You're not off the hook yet, although you were a star the first time. So
I'm gonna give you control again here, Mel. Click on the screen. All right, go for it.
Oh.
Go slowly. Oh, there we go. It's all on.
Very
All
good.
right. Here we go. Here, give me 1 second. I'll share it. Let's see what's going on here. There we go. All right. Go ahead and click. There you go.
Okay. So here we have like a medium power view of 2 glomeruli. My goodness, is this like a PAS stain?
Yeah.
Okay, wow, good. Here you can see that it's in the Bowman's capsule, but looking inside at the glomerulus again, this one appears lobular, hypercellular. There's a lot of endocapillary hypercellularity, including I don't see that the loops, capillary loops are not open. Maybe one here that's open here as well.
That one you just went to before you went to the one way up right there. I mean, a lot of that, I think, David, what is mesangial interposition, right? All around it.
Yeah.
Hmm.
Yes. Yeah.
that's a pretty advanced glomerulus compared to the first one that we saw. I mean, it's just, there's very few loops open and it's very cellular. It's really pretty remarkable. And then the glom on the right, you get a better sense of just how small those lumens are. That there aren't many lumens, which gets to Mario's question about the creatinine.
Yeah, and the
what-
one on the right, you also have adhesion at 9 o'clock, a segmental scar forming.
Right
Yeah, right
here.
in that area. Yeah.
What's the giveaway, Dr. Corbett, that it's mesangial interpositioning here that you're seeing?
Because you see the nuclei all around that open capillary lumen there.
Like this?
Yeah, look, I can't point, but all these nuclei that go around it, right above it. I mean, when
Okay,
you see the EMs, you're going to see, if you remember the previous EMs where you saw how small the lumen was and how big the capillary wall was, a lot of that capillary wall was interpositioned by cell processes and/or in many cases, it can be nuclei.
okay. Thank you. And then is this a cast, Dr. Symbol?
Yeah, Highland cast. Yeah,
Cast.
Tam Harsville protein.
Hey, Mel, let's just move along. We got a little,
Sorry, yep.
thank you, sorry, but
Okay, so here we have a high power view of a glomerulus with Jones silver stain. I guess here looking at, know.
anything different here, Mel?
not really. It's just
Okay.
here again,
Mm.
like tram tracks
Yeah,
of the GBM.
Very lobular looking again, right?
Very popular again. Maybe some more capillary loops that are open, but otherwise same.
You can really get a sense. I mean, it's kind of the same, but it's a lot more cellular and less capillary loops open. But you can see so many of these complex loops, which, it's been a year or so or whatever since the first biopsy.
Oh, so here we have immunofluorescence staining for subtyping for IgG. And wow, it's so we have just IgG3 that came up positive.
So this is after pronase digestion.
Oh, okay. So I guess on the pronase digestion, we've unmasked that there was more to the story here. Just IgG was positive. I don't know what else to really comment on.
Yep.
Okay, was this after pronase digestion as well? So here, I guess
Yes.
on the, so this would be a paraffin sample, and here you can see that it's staining for just kappa. So this would be an IgG3 kappa monoclonal. Lambda was not positive here.
Exactly.
So the globulin gap strikes again.
Mario.
We'll get to that.
This is
Right,
why
next.
Sethi and Ferenza and I say there's no such thing.
Yeah, I
It's
know, but I couldn't let
idiopathic.
you get away with it yet, Dick. We had to have the rest of the conference.
So go to the next slide.
Oh, here, oh, too far.
good.
You're good.
What, just
Okay,
the EM. Yep, go ahead.
sorry, I think there's a leg. So here we have the EM. Here is the capillary lumen with some red cells. Again, you can see that the glomerular basement membrane is quite thickened. You can see mesangial interpositioning here. I guess more here, you can see the electron dense deposits. Would this classify now as like a subepithelial deposit?
no, I
or-
think that's basement membrane, because if you go to the left a little bit, it's, yeah, I think it's kind of twisted or on Foss section of it. Yeah.
It's not that
Okay.
dense.
And then again, the podocytes are diffusely effaced.
Yep.
What's your I guess that's kind of where we
What's
are. right?
your new diagnosis or your real diagnosis, as Dr. Glassick would would only let me say?
Yeah,
So I guess this is like a monoclonal gammopathy of renal significance then, implicating the IgG3 kappa. I'm sure that we're doing this for proteinurias today in GlomCom, but I'm not quite sure which one this would fall under.
Well, is it proliferative?
Yes.
Well, there you go.
So.
So which
yeah,
one is that? There you go.
Proliferative glomerulitis of monoclonal. Yeah, there we go. Immunoglobulin deposits. Thanks. Thanks, Doc.
Exactly.
So the Mayo Clinic, to get back to Dick's point, is it said pattern of injury MPGN. Primary diagnosis was this, PGN-MID. I don't know. I don't know, Dick, if they still, of the pattern of injury, they still talk about type 1, type 2, and type 3 MPGN, but this historically would have fallen into the type 1 category.
So very
Well,
quickly,
Type
I'm
1,
sorry.
type 2, and type 3 are museum pieces.
No, I understand. I
Yeah, but
understand.
They,
Steve's got his own place in that museum, so
Yeah.
we can't.
uh,
So I got to move this along. We have another poll, and then we're gonna find out what actually happened. So how would you treat this patient now that we no longer, now we've got a real
Yeah, would you-
diagnosis? Would you
Sorry,
give
what-
daratumumab? Which is anti-CD38, assuming it's available? Would you give a proteasome inhibitor-based protocol? Would you give a different anti-CD20 drug like obinutuzumab or stem cell transplant?
Get a few more seconds here. All right. Pretty good.
So the highest is 50% at a proteasome bortezomib based protocol. The second is daratumumab. It's there's a lot of good literature on daratumumab for PGN-MID, which is interesting because it's not really, we often don't know what these clones are. The other is obinutuzumab, which is a much stronger, it's a human derived anti-CD20 drug. It's stronger and it's longer lasting, and it's than rituximab, and it's been shown in many rituximab either relapsing or refractory cases to be effective. To me, I'll just say quickly that these kind of, at least the obinutuzumab is kind of rituximab plus, and I'm not sure I'd want to take that route, but I think the first two are reasonable. We know that an anti-lymphocyte drug didn't help the first time, and a lot of times then the next step will be to go to an anti-plasma cell drug, which is bortezomib. But for some reason, the daratumumab has a very high response rate on all these cases. So I think either of these would be reasonable. I don't know how much the literature was available when this patient was seen, when he had the biopsy the second time. But Steve, tell us what was the next step. Because the next step might help determine what you treat this with.
Go to the next slide. So I sent him to our hematology people, Dr. Painter, who takes care of a lot of our patients with paraproteinemias. And they did a bone marrow biopsy, which basically was normal. They did flow cytometry, they did cytogenetics, trying to find if there was an isolated clone that would go along with this, the findings on the renal biopsy, and then the urine and serum immunofixation again and free light chain analysis were all normal. Our original goal was to try and give him daratumumab. That paper had just come out, and Fernando actually sent it to me, the preprint, but what had been published electronically before it was actually in print, if you will. Unfortunately, he couldn't. His insurance wouldn't pay for it. So if you go to the next slide. So he ended up getting Cybor-D, which is cyclophosphamide, bortezomib, and dexamethasone. And I mean, it's pretty dramatic how, when he gets started on it, and he gets started on it here in September, he drops right down, gets all the way down to 1.3. They stop it because he's having diarrhea, and they stop it for several weeks, or I think maybe even a month. And then sure enough, his proteinuria came back up. They reinitiated it with half the dose of the bortezomib, which he tolerated, and sure, he came right back down again. And he was down to almost 720 milligram per gram. And here, Mario, despite how bad his globs look, and we see this in lupus all the time, right? His creatinine was 1.1, his serum albumin had come up to 3.7 gram per deciliter. So he responded quite nicely to the Cyborg D.
Yeah, that is remarkable, that creatinine, when you look at all that, although, you know, it was a lot of proliferation and not a lot of scarring,
That's
although our
right.
sample sizes weren't that great, but that really is remarkable. And, you know, look at that response, and absolutely no response whatsoever to rituximab, and then in a almost complete remission, if you will, with Cyborg D. I'd love to know what daratumumab would have done. You know, it's the Dr. Rajasekharan put the reference for the article in JASN where they had great results with that alone, which is interesting to me because it's an CD38 or 28, I can't remember, but
CD38.
I don't know, you know, does that affect both plasma cells and lymphocytes? Is it like an overlap between bortezomib and rituximab, or is it really, yeah, it's interesting that it seems to work on almost all cases of this. And, you know, we're always talking about clone-directed therapy, but maybe for this disease, you don't need clone-directed therapy. You need just the right drug-directed therapy. So does anybody know exactly what that drug does to plasma cells or lymphocytes?
For today, Dr. Rabi, Dr. Zand was my moderator, and she said that plasma cells are more likely to produce the IgG in and of itself. And so she says that you're more likely to hit the clone if you're just going to take a shot at it to target plasma cells.
It's interesting now that yeah, because and lymphocytes being more IgM, in other words.
Yeah.
Yeah. So, you know, I know that a lot of people, when I've talked to Nelson Lung about this, he basically starts with rituximab just for the practical reason that this is maybe before daratumumab, but just the practical reason that it's so hard to get bortezomib approved for someone that doesn't have an obvious diagnosis of plasma cell dyscrasia, because there's really nothing here. All we have is a biopsy with clear restriction, and look what happened. You know, this guy, anywhere else, he just ends up in end-stage renal disease eventually. And it's very likely, you know, I wonder if with the first biopsy, if you could have taken the paraffin block from the very first biopsy and done, you know, pronase digestion on that, if that would have shown this, and you would have known, you know, 2 years earlier or a year earlier and treated him a year earlier. But
Roger.
that's easy to say because all this information is just developed over from 2020, 2022, at least for most of us. This is still, you know, we're still kind of wrapping our heads around this pronase digestion and this lack of this monoclonal gammopathy of renal significance when you don't have anything anywhere. You don't have it. You don't have a monoclonal gammopathy in the blood or the urine, and you can't find anything in the bone marrow. This is an evolving disease, which, you know, we continue to learn about, and we've had a few of these cases so far, but they never cease to amaze me. And I don't know, to me, one of the take-home message here to me is, you know, MPGN, it gets back to Dick's point. MPGN, don't stop there. You can't stop there. And, you know, unless there's a really, really obvious cause, or, you know, it's a TMA, like Bill said, where the immunofluorescence is negative, or just pure C3, you know, where you think it's a C3GN or something. I think that even C3GN, you know, you probably should do pronase on to make sure that there's no evidence of monoclonal gammopathy, because those have been even described. So, you know, I think that I think that's the point you were trying to make, right, Dick?
Yes, Roger, and I do want to comment about Javier posted a note that this makes a good case for second renal biopsies. I must disagree. It makes a good case for proper study of the initial kidney biopsy.
And that, I think, is absolutely the lesson of this really great case. And, you know, we're all learning, because I don't think I knew much about pronase digestion in the middle of 2019. I'm pretty much guarantee I knew nothing about it. Now, you probably did, because you're writing papers at that point. But, you know, it takes a while for these things to diffuse to the rest of the academic and then to the community. So, but you're absolutely right. And going forward, there'd be no excuse, because I think we really have to look at these cases and don't stop, don't quit anywhere. And including, you know, looking for hepatitis, which is what you brought up earlier, and not giving up on the thought of the cryo and everything else, even though this turned out to be monoclonal related. Any other comments?
Well, this was in 2018 here, and it doesn't really even have our case on it. for when you do pronase digestion, and it should be added. I mean, it should be something where you still don't have the diagnosis and it's labeled idiopathic, then pronase digestion, even the absence of an MGUS in the blood or in the urine should be considered. So I think,
you're talking about the New England Journal of Medicine, MPGN.
sorry, can you not share my screen to see this indications for paraffin immunofluorescence? I thought I shared my screen.
Oh, we didn't see it.
Oh, okay.
This kind of goes back, it's a throwback to the time we never did light chain evaluations by immunofluorescence. And then after we first saw the few cases of light chain deposition disease, Mel started doing it on everybody. It becomes one of those things. It's just one more tool that you can use on these patients to try and, hone in on what the diagnosis is.
And this was in the KI reports in 2018 about when you do for paraffin and where you do the pronase. And it really, the proximal tubular crystal globulin induced nephropathy, we talked about C3GN when you have, or if you have an MGUS in the blood with MPGN, but this is another one. It's just sort of this idiopathic MPGN probably shouldn't be labeled that until pronase digestion's been done.
Now, the only thing is for the fellows and some of the young practitioners, there is an excellent paper published by Sethi and Fervenza in the New England Journal of Medicine by now probably 10 to 15 years ago regarding the pattern of injury of MPGN. And as Bill pointed out, it's very easy to remember. The classification is on the basis of immunofluorescence. If you got immune complexes plus complement, think about these proteinemic disorders, autoimmune diseases, and infection. If you mainly got complement, think about C3GN. If you mainly got fibrin, think about TMA. And if you have a transplant patient, think about transplant glomerulopathy. That's very easy to remember, this pattern of injury, and you pin it down from there.
And that's a really good point.
And once again, remember the globulin gap.
Yeah. Well, there's a globulin gap, Mario, but there was no paraprotein in the blood. So I think you just got lucky on that one. But, it gets back to how far
They
we've
call
come.
it lucky now?
Yeah. It comes how far we've come with MPGN. When I was a fellow, like Bill was joking about, dipyridopyramidol.
Aspirin, dipyridamol.
Yeah, thank you. And we had no idea what this was. Our alternate day steroids, we call it type 1, type 2, type 3. I mean, it was a complete disaster. And I think, how far we've come with, we didn't even call things a pattern of injury. And it tells you, we didn't know what Hep C was back then. It's really a remarkable transformation of this disease over the years. And this it's been a combination of that New England Journal of Medicine article that Mario brought up, where they finally kind of put it in a very good sense. If you see this is where you should go. And we need to make absolutely sure that pronase digestion might be a part of it, unless it's very clear what's going on. Thank you very much, everybody. Thanks, Dick. Welcome back, everybody. Thanks, Mario. It's been great to get back. We'll see you next week. And stay safe, everybody.